Hi everybody. I hope that you're all staying safe and healthy at home. It's been a long time since I've seen most of you, so glad to at least get to talk to you a little bit through this type of format. For those of you who haven't made it to the outpatient setting yet, um, there are many new dot phrases that you will be exposed to, one of which is this clozapine monitoring checklist. As we know, clozapine requires some pretty extensive monitoring for some rare but significant side effects. This can be pretty overwhelming, especially for people who are new to using clozapine, like most residents are, or at least new to using it in the outpatient setting, which is quite different. To help with that, a former resident, Stephen Ching, made a clozapine monitoring checklist dot phrase to help us keep track of all of the important things that need to be monitored when someone is on clozapine. This has been in place since July of 2017. And so for my QI project, I went back to look and see if using the dot phrase has improved the monitoring that happens in the resident clinic for patients on clozapine. So first we'll talk a little bit about clozapine, why it's underutilized, and how this dot phrase is supposed to help make people who are newer to clozapine feel a little bit more comfortable prescribing it. And we'll go over kind of how the study was done, look at some of the results that we found, and go from there. And if you have any questions, please feel free to email me after you've listened to this. So, clozapine. We know that about 30% of people with schizophrenia have some form of treatment resistance. So the National Treatment Advocacy Center looked at the number of clozapine prescriptions per number of antipsychotic prescriptions as a proxy measure for how much clozapine is being prescribed state by state. In their evaluation, South Dakota had the highest percentage of clozapine prescriptions at 15.6% of any state in the country. Most states were significantly lower than that. Oregon, Louisiana, and Nevada came in and basically tied for bottom place with 2% or less of prescriptions being for clozapine. Now, Ohio was higher than that, around 3%, but still definitely not where we would like it to be. Which brings us to the question of why don't people use clozapine? I think we've all seen it work very, very well on inpatient services and have seen our share of patients bounce back from the outpatient setting when someone tries to switch their clozapine to another antipsychotic. So, on the patient side of things, clozapine has some side effects that can really change your quality of life. And they are, unfortunately, the more common side effects, like weight gain and hypersalivation. Additionally, when we counsel people about clozapine, we obviously tell them about the risk of agranulocytosis and myocarditis. And even though those risks are quite low, know that they can make patients pretty scared to take the medication. Another big concern, especially in the outpatient setting, is that when somebody is sick enough to require clozapine, they oftentimes don't have a lot of family or community support left anymore to take them to these lab draws. And they are often sick enough that they have difficulty thinking logically about the risks versus benefits of getting their blood work done. Polypharmacy is also somewhat of a concern. Patients, when they're in the hospital, we know exactly what they're taking and when they're taking it. When they're out and about in the world, they may or may not be taking their other medications I guess clozapine included, as prescribed, which, as we know, can affect absorption and things of that nature. Additionally, outpatient doctors from other disciplines can change their medications, which again can change how clozapine is absorbed and metabolized. And then, of course, the big one that we all think about with clozapine is smoking, lowering their serum levels as well. So there are definitely concerns with starting clozapine on an outpatient basis. I think something that's not actually included in the text here, but is also important, is the idea that patients are going to forget to take their clozapine for a few days and then be embarrassed to tell you and then just take it at the full dose. Which, depending how long they've been off of it when they decide to take it, could be concerning. When we come to the health systems related factors, the first is that there's lack of adequate staff for monitoring. This is especially true in the outpatient setting, where it can be hard to keep up on all of this paperwork for one patient when you have, a few hundred patients that are needing your care. It's also difficult to, follow up with patients, call them, make sure they were able to complete their lab draws and things of that nature when you have so many other patients. Shortage of beds is something that we are all very aware of if we spent any time in the emergency department here. And because of that shortage of beds, it can be difficult to get someone into the hospital when the sole reason for their admission is the initiation of clozapine. Certainly, people who require clozapine will ultimately be sick enough to require hospitalization, but the goal would be to keep them from having to be sick that long or that severely. But unfortunately, there just end up being sicker people who require the beds. And that's really unfortunate because there are quite a few people who require clozapine who just don't have the supports for initiation on the outpatient side of things. Many of these patients have burned their bridges with family and friends, or are so sick that even people who do care about them are unable to encourage them to take their medications daily or do the appropriate lab monitoring. There's also significant service fragmentation in the community. You're reliant upon other health systems and other doctors from other specialties who may change the patient's other medications, which can affect their clozapine absorption and metabolism. And communication can be really difficult. I know that whenever my outpatients needed admitted, I was always hopeful that they would go to Harding because it's a lot easier to get a hold of your inpatient team when they're in-house than when you're continually faxing back and forth requests for records to other institutions. There's another barrier for health systems is a lack of clozapine champions. We certainly do not lack that here. I think we all know of a couple people who prescribe clozapine for most of their patients. And having people like that who do feel comfortable prescribing clozapine in a community does increase the number of people who are willing to prescribe it in an outpatient setting throughout the community. And the National Treatment Advocacy Center data on South Dakota, that was actually one of the reasons why South Dakota, or why it was hypothesized that South Dakota had higher percentage of their antipsychotic prescriptions for clozapine, was due to these clozapine champions being present, both to remind people that clozapine exists and to be there for questions for people who are a little bit less comfortable with prescribing it. Paperwork, as we all know, is no fun, and clozapine prescriptions do come with a lot of paperwork. most of that paperwork ends up falling on the physician or nurse practitioner who is prescribing the medication, because we don't really have systems set up for those things to happen behind the scenes. So that ends up becoming quite a bit of work that we're doing for a single patient. And then lack of ancillary services. So one of the reasons why people fall off the wagon with clozapine is because they're not able to make it to their lab draws, or like to pick up their prescription every 7 days for the first 6 months and things like that. Having even even just a ride to go get your lab work done can make huge differences in these people's lives. And while those intensive case management services are available, they are certainly not as widely available as they are needed. And finally, we come to prescriber-related factors. And these actually come from surveys of people who don't prescribe clozapine, saying why they choose not to prescribe it. Inadequate experience with clozapine prescribing was the #1 answer, which again may be why those clozapine champions from the previous slide are so important in helping people to feel more comfortable with prescribing this medication. There's also a significant lack of knowledge of the side effects. For instance, the risk of agranulocytosis is less than 1%, but in this study, almost half of the doctors and nurse practitioners who were asked about it thought that the risk of agranulocytosis was much higher than 1%, which is in and of itself pretty concerning. There are also unclear diagnoses in a lot of psychiatry. Many people leave their diagnoses as unspecified psychosis or psychosis NOS, depending upon what era you were trained in. And it's very hard for many physicians to say, I'm going to prescribe clozapine for this person that I'm not 100% certain that their diagnosis is schizophrenia or schizoaffective disorder. This study and others have also shown that in the monitoring of clozapine, especially the weekly blood work for the first 6 months, is something that prescribers assume that patients will not be willing to do. And they actually assume that more patients will be inconvenienced by that and that it would prevent them from taking clozapine than patients actually report. So there are a lot of assumptions on the side of the prescriber that this is going to be something people aren't going to want to do, and that really doesn't bear out. And as you can see below, about 1 in 5 patients didn't like getting their blood drawn and didn't think it was worth taking the medication, but about half of physicians thought that patients would be unhappy. So we definitely blow that concern out of proportion a little bit. So how do we overcome these barriers? One thing that's on the horizon of late are these point-of-care blood tests, so similar to your point-of-care glucose test that can be done by a finger stick at home. These things are being available to check ANCs. I have not seen them being available to check with other labs that we like to check during the first month or so. But still, this could be a big game changer for people who have been on clozapine for a month or two and are down to just getting their ANCs drawn weekly. These can also be done in physician offices, whereas, most psychiatrists at least do not have a full lab, but the point-of-care test is much easier to do in an outpatient clinical setting without an attached blood work area. Providing support for people prescribing the medication is essential. As we saw earlier, people really do blow the risks of prescribing clozapine out of proportion to how risky it actually is. So more knowledge, being able to speak with people who are familiar with prescribing clozapine and things of that sort can potentially help people feel more comfortable prescribing this medication when needed. Additionally, having somebody to refer patients to, like a clozapine clinic or things like that, can be helpful. Um, Providing patients transportation is huge. A lot of these patients are homeless or have other challenges that prevent them from being able to drive to get their blood work done. And that can prevent them from getting their blood work and in turn filling their prescription, which is really unfortunate. So even something as simple as a car ride can make a really big difference in compliance for these patients. And of course, having people who have the prescriber's back, clinical pharmacists, case management, to really hone in on taking care of the patient as a whole and not just providing a prescription and watching the patient walk off into the sunset and hoping everything goes okay. Which brings us to the monitoring checklist. This is an EPIC dot phrase that was developed in 2017. It went live July of 2017 and was completed for all clozapine patients during every visit. For those of you who haven't been in the outpatient setting yet, it is clozapine monitoring. And among other things, it includes your most recent CBC and ANC results, REMS patient ID, whether or not the patient has benign ethnic neutropenia, monitoring frequency and dates of change of monitoring frequency, contact information for the patient's pharmacy, which is very, very helpful, most recent clozapine level, and all of the labs that we would get, checking vital signs, bowel movements, things of that nature. And for the obligatory fishbone diagram, when we look at clozapine, the biggest concern is that we might fail to monitor the patients appropriately, which could result in late identification of a side effect. The things that could contribute to that, first, if we look at people, lack of adequate training in clozapine prescribing or even just being early in your training can be a factor in that. Having a heavy workload in the outpatient setting, you're going to have a couple hundred patients that you're taking care of, so it can sometimes be difficult to give enough attention to your couple of clozapine patients. And then limited support, especially for people in an outpatient setting. There just are not, you can feel kind of isolating, and there just aren't as many people around to ask questions of. For the environment, limited time during appointments, it's one of the biggest adjustments for clinic. And then non-compliance with recommended tests. So I don't know how many of my patients had to be reminded for 3 or 4 months in a row to go get their antipsychotic monitoring labs done, which only have to be done annually. So these weekly blood draws, making sure that people get to them can be very difficult in an outpatient setting. And then infrequent clozapine prescribing, people who are not comfortable with prescribing clozapine are not going to prescribe it. And a lot of people who are prescribing don't necessarily have a bunch of patients who need clozapine, especially if they're practicing in a more rural area. You may only have 1 or 2 people who require clozapine. And actually most people who prescribe clozapine, they only have a number of patients in the single digits who are on it. When it comes to our materials, there is not a native IHIS monitoring tool for clozapine. They do have those for other things like vaccines and, when somebody needs their screening chest CT and things like that. But as far as I know, there is not one for clozapine specifically. For methods, there is inconsistent interphysician documentation. This inconsistency is greater in people with less experience prescribing clozapine, perhaps in part because they just don't know what needs to be monitored and what needs to be documented. There aren't any checkpoints in EPIC to prevent us from moving on if we haven't done a certain thing, like preventing us from ordering clozapine if we don't have the attached lab order. We do have those checkpoints on the inpatient team now, but they don't exist on the outpatient side of things. And for me, one of the biggest barriers for physical monitoring of any patient, let alone a clozapine patient, is the lack of in-house lab or EKG in most outpatient psychiatric settings. It is, of course, much easier to walk somebody across the hall to the lab and to get their EKG done than it is to give them a list of places that they can drive through to get it done. And each and every one of these factors can make it more difficult to monitor and may end up leading to ultimately a failure to monitor, which, as I said earlier, can lead to late identification of significant side effects. So, how the information you're about to see came about is the charts of all epicenter patients on clozapine during any point in their care were identified, split into groups based off of whether they started clozapine prior to that July 2017 start date for the monitoring checklist or after. And then the notes of from clozapine initiation were reviewed for documentation of side effects and lab monitoring. So first, there were 8 patients identified who had started clozapine prior to the checklist. They were all male, around 27 and a half years old. About 62% were white, and 13% were black, and 25% were Asian. And all but one of them was diagnosed with schizophrenia, and then one was diagnosed with schizoaffective disorder. When we look at the 12 patients that were identified as being starting clozapine after July of 2017, they were a tad younger, with a mean age right around 25. And there was a slightly higher percentage of people with schizoaffective disorder. And there were no Asians. About 92% were white and about 8% were black. And about 25% were female. So as far as what was recorded when, the green here is when we look at the notes for patients prior to clozapine, or for clozapine initiation prior to July of 2017, that's all of the green bars, and then the blue bars here are the whether or not this thing was recorded in the notes of patients after the checklist was initiated. So the first thing would be the REMS ID, which was not put in any of the notes in EPIC for any of the patients prior to July of 2017 when the checklist was initiated, but was in close to 70% of the charts for people after that initiation. The benign ethnic neutropenia status was much higher in the documentation after the CMC was in use. ANC, interestingly enough, was actually present more in documentation prior to the checklist initiation as opposed to after. EKGs were documented more frequently after the checklist initiation, Same with constipation, sedation, weight gain, height. Um, Temperature was similar to ANC, seen more frequently prior to the checklist initiation, but heart rate, seizures, and important comorbid conditions like diabetes were all more likely to have been included in the documentation after checklist initiation. So the next question becomes, so overall, excluding ANC and temperature, we're at least documenting better that we're monitoring these patients. So the question becomes, does that change how long people are on the medication? We can see here that at the time of initiation, we had 8 patients that were started on clozapine prior to the checklist and 12 patients who were started on clozapine after the checklist was initiated. At the time of their clozapine initiation, 100% of those people were on clozapine. But when we look 3 months out, the control group has lost 2 people, so only 6 people are still on clozapine. Of those 2, one had significant cardiac side effects and the other had problems with compliance. We've also seen a drop-off in the group of people who were started on clozapine after the checklist, down to 9 from the original 12. One of those people had significant cardiac side effects, and 2 of them were having trouble with compliance. At the 6-month point, the person who was having trouble complying in the control group is now back on clozapine. So we have a total of 7 people on clozapine in that group, and then in the group after the checklist was started, we have 10 total. But it's important to note that at this point, the total number of patients is 11 because one of the initial 12 had not been on clozapine for 6 months yet. And that drop-off is bigger when we get to the year mark. Only 8 of the original 12 people have been on clozapine for a whole year, or that it's been a year since their start date. And of those 8 people, 6 are still on clozapine. One that is not on clozapine because of significant cardiac side effects, and one was not on clozapine because of problems with compliance. And the control group held steady at 7 people on clozapine. So where do we go from here? The first thing would be that the sample sizes were small enough in this that none of the data that I showed you reached statistical significance. So finding a way to increase our sample size would be important. And then, being able to actually tease out what the patient outcomes have been before and after. We kind of got into that a little bit with looking at how long people have taken the medication, and the assumption being that if you're still on it a year later that things are going well, but that may not always be the case as far as response to the medication is concerned. And the other thing that I did not do that would be interesting to look at is to see how well we're following the guidelines of after someone has had 2 failed antipsychotic trials, that they should be trialed with clozapine, and if that is happening in all the appropriate instances. I would really like to thank Dr. Hyman for helping me out immensely with this project, Dr. Niedermeyer for looking over slides and all around being an excellent program director, Dr. Svensson for his help with some of my background data and being a support during this process, and Dr. Huff for listening to and reviewing this PowerPoint ad nauseum. Thank you all so much. Please feel free to email me with any questions that you have, and there are my references. Thanks.